Okay, well, good afternoon, and these are our daily updates, so they're going to be a bit briefer, we think. More time for questions on that, and since yesterday, we continue to work at a number of things that are command table. Issues that come forward, ongoing things around laboratory testing, capacity issues around that. We continue to look at ongoing reports of other supply issues. Something's moving slower, but always progressing in a positive direction. We continue to look at a number of aspects related to the declaration and roles of essential staff and other sites that are maybe not specific, and how to clarify some of those. We continue to deal with some of those aspects. And at the same time, we continue to get monitoring from the global perspective from the United States, working again with our FPT, Federal Provincial Territorial Partners, from our Special Advisory Committee, and of course talking to our local MOHs at the local health units on how things are going there and updates on the processes, working with our command table on assessment sites, hospitals, other centers, and long-term care, and retirement homes and all those aspects there. So there's many things moving as we continue to ramp up and deal with it. So from the number standpoint, in that, so now we're, depends if we started with the school closures last Thursday, Friday. Of course, a lot of the restrictions came in on Monday. So where are we? We're in day, you can either say from one day, it's day 5 or 6, and the other it's day 3. In that, and I think that's important to note as we track along. So trying to give a sense of how we're doing. Yesterday you were asking that we had just 9 more cases added. That was at that time in the morning. So Dr. Yaffe is going to give you an update of some of those numbers as they are today, and you gave some more numbers or update at the evening report for you. So we're trying to move it from there. So over to you, Dr. Yaffe, for the Ontario numbers.
Thank you. So as of this morning, we now have a total of 212 cases, confirmed cases in Ontario. Still the 5 resolved, and as you know, the 1 person who's deceased. We have over 10,000 negatives and over 3,000 that are under investigation. So the number that are going to the lab is going up quite quickly. The good news is the lab capacity is going up. We have the Public Health Ontario lab itself has increased its capacity to test per day. And we have a number of hospital labs coming on that will eventually increase our capacity to 5,000 tests a day. So the vast majority of our cases still are related to travel outside of Canada or contact with a case. Very small number where there hasn't been a connection made with those, and of course the health units continue to do their investigation. So, and we're working very hard, I have to say, to figure out the best way to present the data, considering that the numbers are going up quickly and the situation is rapidly evolving.
And of course, you've seen the international numbers, and right now we're mostly watching to see what's happening south of the border, and their cases are 6,332 as of this morning, and 107 deaths. So those numbers are changing considerably each day, and it's interesting also to see that the European total, or the countries outside of China, equal China at this stage with cases and that. So the other ones are working their way through with, especially the numbers are concerned in Italy, and the ongoing ones in other countries in the EU. As you heard some messaging, we're waiting for some definitive messaging on any changes in border from the federal government in there, and get that definitively from our Chief Public Health Officer. I haven't received them as of the time of this conference in that regard. I know you had questions on that yesterday, and right now we had left it with Canadians and Americans, but we hear there might be some updates, but I said I'm officially waiting for updates from our federal counterparts on that matter in that. So I think we get a sense, or my sense is that Ontarians have taken this seriously. Many are limiting activities. There's always some who do something different a little bit, but I think for the most part I walked around and see things in the streets because I have to get down to the command center, And I think people are listening and taking care, and I want to encourage them to keep at that. As I said, we're in day 3, if you may, of the total, and from some of the parents with the children at home, it's obviously seemed like more than a long weekend, and they're trying to deal with those issues in there. And I really am encouraged by all the different groups, both volunteers and companies and media, that are coming with ideas to help people, I guess, try and make social isolation sociable and livable in that. And because it is a change for a lot of people, it's not easy, and some face more difficulties than others, especially when we're dealing with limitations on certain facilities. And we're trying to understand and work with that as best we can, and to maintain the controls we have in place, the social distancing, as we wait for, we hear large numbers of Canadians returning, especially from south of the border, and we hope to enter them into the monitoring and isolation process and keep them advised. Continue using our self-assessment tool, and our assessment centers, the numbers of assessment centers have been expanding and continue to do so. And we're having consultations also with our partners in federal government and that, and with Indigenous and First Nation communities on how we might strategize to deal with their unique issues if and when they might occur on a proactive basis. So that's been important as well in that. So I think there's many things happening and planning and preparation in that. And as I said, as of yesterday, we still had that one unfortunate death. And we're continuing to monitor to see if there's any other ones of issue. We're trying to get some databases clear on, can we have updates of how many are hospitalized accurately, and other kind of information to that. So we keep trying to look at our data reporting, how we can make sure we're doing it in a timely fashion that's informative to you and the media and to the public at large on how is the whole thing going. So we're working on that at this time. So with that, I'll open for questions because there's time limit. Yes, go ahead.
You mentioned the testing, and that we would shortly get to 5,000 tests a day. Can you say when that might be? Will it be a week? Will it be 2 weeks? And how many tests are being done a day currently?
I can't actually say exactly when we'll be up to 5,000. Hopefully soon. I don't know the exact date. I think we're doing just under 1,000 right now a day.
And this 5 resolved cases, it's stayed at 5 for quite some time now, I think 2 weeks.
Yeah.
What does that tell you, and is that concerning?
Well, actually, we've been working with Public Health Ontario and looking at the literature as we learn more and more about this new infection in terms of when is a person no longer infectious to others, and looking at criteria that hopefully will not require lab testing. Because right now we have very strict criteria. They have to have 2 negative specimens at least 24 hours apart. And we're looking at changing to criteria so that I'm sure a vast majority of our cases have recovered. We just haven't, they haven't met the criteria, so we're looking at changing that.
Yesterday you said people who don't have symptoms shouldn't get tested, but unless anything's changed, the people can still be positive but not have symptoms, and they can still be infectious. Isn't it just best to cover all bases and test everybody, or is this just like an infrastructure thing? We don't have enough to do that.
We keep asking our experts at Public Health Ontario and also with Public Health Agency of Canada, and the stance is still, if there are some people that are asymptomatic, if they are shedding, it's not much at all. And so therefore they don't seem to be of concern for infectious rates this time. At least the science indicates that. We continue to be advised by those experts as they continue to do the research. Right now, if you were more concerned when you develop symptoms, then you've obviously had general system impact by the virus, and you're probably replicating quite a bit, and you're reproducing more and potentially secreting a lot more. So I think we'll continue to be directed by our Ontario and national and international experts if there's any change in that significantly. I know there's many people have some reports they think so, but one of the challenges they have there when they think they found someone asymptomatic is that you're looking at bits and pieces of RNA in their nasopharyngeal tract. It may be vibrant, it may not, 1 or 2, because they're very sensitive tests. Does that mean they're highly infectious, or you just happen to find it? And this may seem like wordsmithing, but that's what the science gets down to and their interpretation, and we have to wait for the experts to come back and say, has there been any change in that? Right now, to test everybody just because they want to get tested, we don't have that capacity. We want to make sure that we have the capacity to test those who really do need testing and to do it in a timely fashion, because especially for some, in some clinical ED and inpatient side, they need to know fairly quickly. There's some other unique situations that we do need to know because it affects your public health response, or in the previous case, the clinical response. So some have a need more than others, and they need to have it not held up because there is processing time. They need to be expedited through the process because it has further impacts.
Dr. Williams, actually I'm not sure if it's for you or for Dr. Yaffe, but in regards to social distancing at workplaces, given some of the recommendations you've issued as well as the emergency orders from the Premier and from Cabinet, are employers in workplaces required to bring in some sort of social distancing within their workplaces if, for instance, they have more than 25, 50 people in a space? And what do you say to employees who might be afraid to speak up about that sort of a situation?
Well, we've asked, and I know the Premier is very positive about that. Retailers and company and owners would only want what's best for their staff. I think we're asking them to work with that. I found a number of employers have already taken steps to do so. Try to work from home, explore virtual methods, distances you can do it. Will there be ones that may not adhere to that? There could be, and I guess we'll have to understand how we might be appraised of that or be aware of that and make some suggestions. We haven't gone to any further extension to actual workplaces per se. It doesn't mean that the Premier with the order and the Cabinet could not go there if they felt the need to. They didn't go there yet, but I guess they'll have to be informed by feedback and situation that the government is appraised of.
Are employers who do not provide social distancing at work, are they actually violating?
Was not in the order right now that the workplaces per se were not in the order in that, but as the Premier said and as the Minister said, they can amend those and add more on as they see the need to.
And this, I think, is for Dr. Yaffe probably, but I've heard some concern from family doctors in particular that they simply do not know what they are supposed to do with a patient who presents to them with the symptoms of COVID-19. It's unclear how they get them referred for testing in terms of the messaging that's it seems to be very inconsistent messaging coming either from the Health Ministry or the Ontario Medical Association or the College of Physicians and Surgeons. What should a family doctor do in that situation?
Well, that's not good to hear, actually. I think we have been working very closely with the Ontario Medical Association, and I know they have sent out many communications to physicians. And of course, if the physician is unsure, they should be contacting the OMA. They can contact us, but I think the OMA would be able to give them more of a clinical answer. I mean, my husband's a family doctor, and certainly doesn't ask me for advice. But anyway, you know, I think that the bottom line is that we want them to see less patients. They can do it more virtually. And if they're concerned, the patient can also do the self-assessment tool online. But if they're concerned, they can send the patient to an assessment center. And I think that information is available to them. So hopefully they're not seeing many patients with a question of COVID. They should be sending them.
Well, that thing about sending them to the assessment center seems to be the crux of the concern that I'm hearing, is that it's unclear how you refer someone to an assessment center. Are you supposed to phone the assessment center? Give them a referral? How does a person get seen at an assessment center?
Well, I'm assuming the patient can call themselves, the doctor can call, but, you know, we will look into that. I don't know the specific.
Telehealth.
Yeah.
No one can get through on telehealth.
We're staffing up considerably with another 140 odd nurses added to it, so we're trying to improve that. We're trying to improve the overall flow of that information so that we'd like to use the self-assessment tool first in that, and that gives you advice where to call. Is there loads in each section that's slowing it down? There is. Is that acceptable? No, it isn't. How do we fix that and resolve that? We need to do that, and we're working at that as quickly as we can, because the people shouldn't be left, especially those just returning. What am I supposed to do? What advice and that? And the physicians, of course, if they're not tied into the system, they're asking, well, then what am I supposed to recommend, as you've alluded to? And we're trying to work with the OMA on that one there. So the flow of requests, like we said, the self-assessment tool went out Sunday evening. by midnight they had 94,000 hits. So the demand and request for information is extensive, overwhelming, so we have to keep trying to meet that. And because if they're not informed, then they won't be making the right decisions. So we're trying to look at all the system improvements throughout to make it more efficient, effective, and I would say timely for people to contact. So the time delays right now in our minds and in minds of telehealth and others is not acceptable. So we have to rapidly look at trying to improve that.
I don't mean to hog things for colleagues if other people,
Yeah.
I just want to follow up one thing here. If I feel like I have the symptoms, not me, but if somebody out there listening, watching, feels they have the symptoms, what do they do in terms of getting to a self-assessment center? Do they just show up? Do they have to see their family doctor? Do they need some sort of referral?
Well, first they should try, if they can't get out of this, try to implement the self-assessment tool, which is on our website, which will help them direct what to do. And if it says call telehealth, they should call telehealth. They really shouldn't call their own doctor. And they can call the assessment center and say, I'm coming. I think the assessment centers strongly prefer somebody makes an appointment because they don't want people lining up. That's not a good situation.
All right. I had kind of a double-barreled question relates to a lot of emails I'm getting from readers. What do you do if you've got someone in your house who's come back from foreign travel and is asymptomatic and is self-isolating? Do you have to self-isolate too? And then a quick follow.
Okay, so you got different scenarios. So a person has traveled and they're asymptomatic. They've known they have to limit their social activities, isolate, not go out, except, if they had to go out and grab something, they could, but they're supposed to stay in the house. Or out and around, they go for a walk. If you're living with them,
Where do you have to self-isolate too?
no, you don't, because you're not connected. Now, you need to monitor. Now, if your partner, whoever in the house you're with, develops symptoms, then they do the self-assessment tool, so they then become potentially a person under investigation because they have a travel history, or it could be a person with a case contact they know of, and they develop symptoms. Then are they going to be tested, or they get tested yes or no, or a case that goes through the flow process? While they're going on, I have to assume that person could be a potential case. That affects me, that I have to do then some more further monitoring myself because I could be a contact of that case. I still can do my normal activities. I'm not really attached yet to a case, but I have to go on the pretense that they could be a case. And I'd rather say after 24 40 hours when I got the test result back, during that time I did not go out, I didn't do this. So I did what I was supposed to do because I'm now connected to a case. I'm like my partner was in that sense. You're doing your comparison because they had a travel history. Now I have a case contact history, and I have a new status at that stage.
And just a quick follow-up to that is, what is the recommended for treatment who think they're positive but have not been tested? I'm assuming treat yourself as if for the flu, and if you have trouble breathing, then that's when you need to get to the ER. Is there anything more?
Well, I mean,
Should you take Advil? Is that a good medicine? Because there's some debate out there whether Advil is good. Could have some side effects or some troubles.
well, I mean, it's symptomatic relief, right? It's just like if you have the flu or something. So if you're coughing, you take something for your cough. If you have a fever, you take something to reduce your fever. Keep up your fluids, get some rest, eat healthy, all the things you're supposed to do normally. But if you're starting to feel trouble breathing, that's quite serious, or high fever that's not going down with medication, or you're just feeling really sick and weak, you should, either try the online assessment tool or at that point call your doctor or the telehealth.
I heard the report about the NSAIDs versus Tylenol. I've asked some people, what's your view of that? It's just one article someone wrote, and what's the foundation of it? So anything that's out there, we try to look into and see if there's some merit to it.
Doctor, whoever wants to answer this question, we're getting contacted by nurses who've been contacted several times. Ambulances pick people up, they're wearing full PPE or the full gown, and then they're coming to the emergency room and they're wheeling the patient into the emergency room wearing everything. The nurse that receives that, the staff that receive it, don't even wear masks. Is that correct? Is that protocol? Should that change? And it may be protocol, but you can see the fear factor there.
So the protocol, why the ambulance drivers do it, if they go out and pick up someone who's had supposedly, well, they don't know what they had. And maybe they've heard in the report in they're having a respiratory issue. So they have to assume they don't know what the cause is. It could be airborne, as in measles or tuberculosis or things like that. So that's part of their protocol because they have to assume the worst situation. If they feel and assess that they're bringing in a person with unknown respiratory infectious case coming in, they have to call ahead of the hospital. They should receive that patient accordingly with proper PPE for the staff. So that's part of the notification. If they think they're bringing in a potential respiratory case, especially if they think it might be COVID or some other respiratory infection, then because the hospital staff also can't be sure what it is until the testing's done, those staff receiving that patient, looking after that, have to wear proper protection similar. And until they know. Once they know it's COVID, then they can say, well, the direction is it's droplet spread. Then under the direction and it would be given out, they would take certain steps at that time. Until you know, you have to assume that you don't know. And you have to take proper precautions and make sure that person goes into an isolation type setup and the staff going to see that person until the assessment's done are properly protected.
Jamie, just one more if you have one. If not, it's
So
not.
the nurse that's receiving, and we got these from several nurses, receiving a patient after the ambulance, the EMS is wearing proper PPE, they shouldn't be taking in patients without even a mask on.
We just have to make sure that the institution, each one has set up the protocols properly and they're following it. Those are standard IPAC principles.
Antonella, then we have to go to the phone lines. I'm sorry.
Are there any exclusions to the self-quarantine rule after traveling for frontline workers, paramedics, anybody, long-term care staff, anybody?
Right now, we're reviewing that matter, and the various institutions are looking for communications out from my office to give direction on that matter. It'll be forthcoming.
Okay, this is the last.
With calls and also just the supply shortage. I mean, how equipped is Ontario's healthcare system to deal with this? Because we know it's only potentially going to get worse with more cases coming forward. So how equipped is the province for this?
Okay, so that's the command table, and with Ontario Health, and with the regional ones. So how's each region doing? What's the status and inventory? Because each one's equipped differently, and so you're asking a variety of different institutions, are they equipped to respond to a variety of different things in a variety of different ways? So each one has to do their own assessment, their own operation procedure. We call it COOP plans, continuity of operations. What are you going to do in scenario A, B, or C? Are you prepared? And then how are we going to prepare the system for that? How are we going to reallocate, as the minister talked about? Are we going to look at some different sites and locations? This is all first a institutional response, then you look at a regional response, and then you look at a system response. So the answer is all the above are important, but each is as good as the strength of each small part. Everyone has to do their part of not only assessing their current status and what are you going to do in A and B and C if things progress, and how's the region going to respond, and then how provincially we're going to respond.
Okay, we have to get to the phone lines. No, just remember not to put your phone on speaker. One question, one follow-up.
Next question is from Moira Warburton at Reuters.
Hi. So my question is the testing hold up still about swabs, or is it about something else? And sorry if this got answered or my phone was cutting in and out.
Ask the question again.
Can you ask the question again, please?
Sure. Can you hear me? Yes. Okay. Is the testing hold up about swabs, or is it about something else?
If I understand the question, is the testing capacity about, is that what you're asking? I think it's some hold up. I heard something.
Sorry. Is the testing hold up about swabs, or is it about something else?
The testing, well, with the number of tests pending is there's a load issue and processing. That's one aspect. The other aspect is the time we're trying to open up our satellite centers to take that load on. And the other one is we've got to make sure all the different components. You've got your equipment at your sites, you've got your reagents, and you've got your staffing to man those, as well as the swabs. And we are working with our federal counterparts, and we understand there's some potential large orders coming in, and they're doing distribution, but we're going to be informed on that. So we have been in dialogue because each one of those is important parts of the system performance in the labs.
Okay, very quick follow-up, please.
And do you have a sense of when that capacity will be at full volume?
The 5,000 a day, we keep asking our public health lab people on that, knowing if you get one part done, you have to get all the components. So when we have all the swabs we need, all the reagent we need, and all the equipment and other sites up, we'll be at that 5,000. And there's a number of moving parts there, so I can't tell you exactly when that'll be. They had anticipated in 2 to 3 weeks back a week or so ago. So I'm still anticipating. We moved up, increased some volume, and we'll keep increasing that up on there. So there's a lot of moving parts there, but that's where we're heading towards.
Okay, next question
is from Jeff Gray at the Globe and Mail.
Hi, everybody. I just wanted to ask, to clarify, you did address this, but and so did the Minister of Health, this issue of healthcare workers who, if they weren't healthcare workers, should have been self-isolating after they came back from travel, were told not to. You said you're working on some new guidance about that. Is that what I heard? And will it involve some sort of tracking of where this practice took place to see if there's any problems that result from it?
Okay, just the last part was the tracking of.
Well, will you track? Will you be able to track which hospitals did allow people to come back sooner than otherwise?
Oh, well, that's the thing. We find different hospitals have done different things. So there's a sense from the command table we need to put out a communication that would ask everybody to follow the same processes. So that's what we're hoping to put together and send out. So there isn't this variation from site to site, and it's much more consistent. So we're trying to remedy that problem.
Okay, quick follow-up.
The Minister of Health did say that these workers should self-isolate just like everybody else. Is that what the decision will be?
That's our current stance, and we're going to work through our command table to say how that's going to be affected, because there's different issues involved in HHR at the hospitals. We want to understand that. So again, that's part of our communication on a go-forward basis.
Okay, next question.
From Manur Yavar at City News.
Hi there. I'm wondering, so recently a group of healthcare professionals in Ontario sent a letter saying, or asking governments for COVID-19 protection, saying they don't have access to necessary personal protective equipment. What's your response to that?
My response to that, if they're in one of the centers and that, they should approach the regional planning tables in that, and or through their organization. I'm not sure if you're talking about actual institutional people, you're talking about private, you're talking about a clinical group. There's a variety of groups out there. We would ask that they approach the regional table to see about that issue per se. If it is a system-wide thing with a certain group that is a pan-Ontario group that needs a decision, that's something that will be forward to our command table. But we've been trying to work through at our regional tables to look at those local needs and see how they can be dealt with.
Okay, quick follow-up.
Do we know how many healthcare professionals, including nurses, have been tested for the virus yet?
How many healthcare workers have been tested?
Including nurses, yeah.
Well, because a lot of them have come back as individuals and been tested personally in that, if they have, we don't usually record their profession where they're at. If they actually went to a workplace, we may know that. So no, we don't have that distinct number at this stage.
Okay, next question.
Next is Alistair Sharp at National Observer.
Hi, just kind of somewhat related to that. A parent of a very vulnerable patient has told me that home health care that her son requires, she asked them to use masks, and they said that directions were that it wasn't mandatory, and quoted something called equitable and managed distribution. I'd like to know what that is, and whether it is likely to change to ensure that the most vulnerable patients are protected from their nurses, who could potentially be carriers, asymptomatic carriers.
Okay, I think I got the context, if I can get it straight. Vulnerable people If they're having, I assume the vulnerable person could be in a home setting, could be in a institutional setting, a retirement home, hospice, or somewhere. If it's the latter ones, anyone who's come into there has to pass a screening test of without travel history in the last 14 days, contact no one in a known case in 14 days, and they're asymptomatic. So therefore, they should not be in if they are if they're symptomatic, travel, or case. We've already answered the question about asymptomatic transmission, and our stance is still that, well, from our experts, we do not have the evidence that they are transmitting while they're asymptomatic. If you're talking about someone in a private home, in that situation there, I would ask that the family, we've asked them, the vulnerable people, especially of a certain age and over, that they would continue to stay in their home. I think visiting, family members are visiting, one, you would want to make sure you did your own assessment, which is if you travel the last 14 days, don't visit. Use computer, visit, or FaceTime. If you have been in contact with a case, don't visit till 14 days after and you're asymptomatic. Or if you're sick, don't visit either. And so you're doing your own assessment for the protection of your loved one and your family member, and try and use other virtual methods. If it's really vital and you need to get in there, then you're going to have a unique challenge of how you might do that in that situation. On an institutional setting, that's one thing. A home setting is a different one.
Okay, quick follow-up.
Yeah, separately, the Minister of Health has talked about a target of getting the testing results back to a 24 to 48 hour turnaround. It's currently at 4 days. Given that there's an explosion of requests for tests, and there's at least a week, perhaps 2, it sounds from your previous answer, before there's going to be more supply, how do you intend to bring that down in the next week or so?
Right. So what we're trying to look at there is, as one of the other members here asked already, is that we want to make sure we do first priority testing so that those who need to know urgently would still get it done in a timely fashion. For example, if you have a patient admitted in the hospital that you think it is, you need that test result back as quick as possible. Even quicker than 6 hours if you could, but you've got to get the sample in there. If it's a person in ICU and you don't know the diagnosis, you need to know that. If it's someone you're considering admitting, you need to know that. If it's a healthcare worker that potentially is a problem, has been in some exposure, you want to know that as soon as possible. If there's some other unique ones, and we're trying to work on how that works with our First Nation and communities, etc. So they, because of unique circumstances, should have a turnaround rapidly. The rest we can do that, because right now, if I came back traveling from somewhere and I have some symptoms, sort of mild, and that I'm at home, I'm coughing a bit, and if I send a sample in, I'm told to also isolate for 14 days, and I'm symptom-free. If I get a test result back, I'm supposed to isolate for 14 days until I'm symptom-free. So whether I know or not right that day, it doesn't change how I'm supposed to behave. But I think from a standpoint, if I got a test, I should get informed sometime what my result is. So the urgency is not as much, but the need to get the results back is still there.
Okay, we only have time for one more reporter.
Laura Eggerson at CMAJ.
Hi, my question is that many family doctors are telling us that they, and as well as nurses and people in the community who see patients, do not have the correct protective equipment, don't know how to get it, don't know when they are going to get it, and some patients are going to bypass or somehow slip through and potentially endanger both them and their other patients. For instance, if they're treating palliative patients and they need to get in to see them. So what are you doing to ensure they have the protective equipment?
Do you want that one? Okay.
No, not really.
You want me? Okay. What we've been trying to say all along is that during the regular flu season, when there's people coming in to your practice that you're supposed to ask them, are they sick and do they have respiratory symptoms, whether it's influenza or potentially COVID-19, you're supposed to call ahead and make that appointment. And then you're supposed to either decide whether you're going to see them at that time or wait till later in the day when the waiting room is empty and assess. If you think that's combined with travel history and conduct of a case, we're saying it would be better, you say, go to either call the self-assessment tool, call telehealth, all these processes we've talked before. By bringing them into your office practice, you put some pressure on the other patients and your system and your staff that you really don't need, because there's all those other patients that still need to be seen. and you don't want to interrupt your practice on that basis. In that, so we'd rather not try to test them there. So it's part of your pre-screening. If they're, as you say, if they're people who choose not to, and that's always a challenge to anyone. And of course, you hope your reception staff pick it up that someone's coming in, they're quite hacking and coughing. You just say, well, you didn't call ahead of time. Put this mask on, a surgical mask, and go and sit over in the far corner, or wait outside until we talk to you later. And so they have to be fairly stringent and firm on that. And the people who didn't follow the due process, we've asked them to do that. So in that sense, what kind of PPE do you need? You normally use what you normally do in your practice there. We're not asking that you get involved heavily in doing COVID-19 testing. One is that we haven't got all those kits out there to do. We have our assessment centers set up to do that, and so we can handle that way. If you need to wear a surgical mask because you're looking at a wound or a site on a follow-up patient, you can have your surgical mask that you can use 3 or 4 or 5 times because it's for you, or for you to protect the patient from you, not the other way around. So there's ways they can deal with it. We try to keep looking after those supply issues, whether it's gloves and masks, and it depends what kind of your practice is, what kind of patients you're seeing, and how you minimize those exposures. We're asking you to do a lot more with our new codes through virtual, and there's methods to do that billing, so you don't have to bring everyone into the office. So there's many ways you can do it to limit that. And so we ask you to talk to the OMA and others on that. Do that if you have questions, and consult with their respective authorities, and we'll try and give as best advice as soon as we can in that regard.
Quick follow-up, and this is the last question.
Follow-up, please. The issue, though, I think you guys are kind of skirting this issue. The issue is there doesn't seem to be enough, even masks. People are running out of gloves. They don't have personal protective equipment, and the doctors are concerned about this.
Okay.
How do they get it?
Well, again, if we're aware of that and it feeds through either through the Ontario Medical Association or through our regional offices, we can look at that. Some people, I get various reports. Some find it's easy to get it. Some have more difficulty. So it may be an ordering problem. There's different things in there. So it's varying from area to area. So we have to be dealing with that individual and how they get tagged into one of our supply chain issues.
Thank you. That's it. Thanks, everyone.
Thank you. Thank you. Everybody spread out pretty well.